Welcome to lecture number 6. Today the topic is opioid related disorders. This topic has more of practical and viva questions and less of theory questions. The theory question I have seen is mainly on harm reduction strategies, because harm reduction is most famous about opioid. But in practical and viva, you might get a case of opioid use, you might get a case of injectable drug user, and there are a lot of viva questions related to pharmacotherapy. I'm just giving you an orientation to this chapter. So in theory there is very limited question like harm reduction, or they may ask opioid withdrawal. But in practical you might get a case. More chances of getting a long case in substance use disorder is either alcohol or opioid. Did I speak about long cases in the previous class? I'm not sure. Suppose there is a psychiatry long case, 100 marks, MD final practical. Then it can belong to the core psychiatry, that is the adult psychiatry, or addiction psychiatry. In addiction psychiatry, the long cases are either alcohol related disorders, opioid related disorders, because these are the patients that are admitted, hospitalized. So you only get a hospitalized patient in this. Very rarely a cannabis induced psychosis if he is admitted, because cannabis usually we don't admit for de-addiction. Okay, and in some of the places you also get a polysubstance use. Have you seen a patient of polysubstance abuse? These are the 4 long cases. Addiction psychiatry, the short case can be an OPD patient of tobacco, cocaine user, but very rarely. But the long case in addiction psychiatry is alcohol, opioid or cannabis mainly. My own exam long case was alcohol, MD final practical passing. Do you have seen all these cases in your departments? Have you seen a polysubstance abuse? So opioid is one of the long case. Why is this patient admitted? Actually, opioid use can cause disturbances in mood, behavior, cognition. Have a look very carefully. If you have read mental status examination, it has components like behavior, mood, thought, perception, cognitive function. These are the 5 basic key components of mental status examination that I teach to undergraduates. Have you ever heard about a case of opioid induced psychosis? Have you ever heard a case of opioid induced psychosis? So it is less common to have per se thought and perceptual disturbance. You will never say heroin has caused delusion of persecution, morphine has caused auditory hallucination. Less likely, a little less likely. As compared to alcohol-induced psychosis, opioid-induced psychosis is more likely or less likely? What do you say? The Kaplan psychiatry says that opioid causes more of mood, behavior and cognitive changes than of thought and perception changes. So you should be knowing that this statement is written in Kaplan. Okay, what do you mean by opioid? So these mood, behavior and cognition changes may mimic a psychiatric condition. What do you mean by the word opioid? Opioid is any substance, either natural or synthetic, that binds to opioid receptors and produces opium-like effects. So if somebody asks you what is the definition of the word opioid, any substance that is natural or synthetic that binds to opioid receptors and produces opium-like effects. Okay, so by classification, opioids can be endogenous opioids or internal opioids. That means produced inside the body. But we are more interested in exogenous opioids. Exogenous opioids are further divided into natural, semi-synthetic and synthetic. Your natural include morphine, codeine. If you remember two examples of each, it is sufficient. Semi-synthetic include heroin, which is diacetyl morphine, codeine, and your buprenorphine is also semi-synthetic. Your synthetic includes ethidine, tramadol, fentanyl, dextropropoxyphene, and methadone. Little the basic Viva questions. Endorphins, dynorphins, and enkephalins. Very basic Viva question. The classification of opioids. Have you copied this? I have purposely mentioned here methadone and buprenorphine because you must be knowing that it is very common in the Viva to ask you the differences between methadone and buprenorphine, because both of them are OST, opioid substitution therapy.